For tonight, I'm going to go over the initial presentation, initial management, transport concerns, and then we'll go through a few cases for each one of patients that had these injuries and how they were managed and things that we could do better or things that went well. So who am I? I'm one of the newer burn staff at UW. I've been here since last August. I did my general surgery training at Hennepin County in Minneapolis, which has a pretty busy burn unit. And then I went down to Los Angeles for a year and did a burn and surgical critical care fellowship for 1 year. So it's been a good time here so far, getting to know everyone at Wisconsin. All right, so going to our burn basics, I always like to start with going through sort of the basic ABLS algorithm for how we take care of our burn patients. And I think this is especially important when it comes to the summer burn emergencies, because if you see someone who's got a really bad firework injury, it can be incredibly distracting to everything else, and they can have a lot going on all at once. So we always come back to A, B, C, D, E. And this applies to every burn patient every single time. So we're going to go through each one of those steps quickly. So first, A is for airway. We all know this. We assess their airway first. Even if their arm has been blown off by a firework, we want to make sure we're assessing their airway, that their airway is patent, and that they don't need to get an advanced airway in place quickly. So you're going to ask them to talk, and if you're concerned they might have C-spine trauma in addition to this, you'll want to make sure that you're maintaining C-spine precautions. In someone who's unconscious, we obviously have to consider if we need to do an advanced airway to keep their airway safe. For B, breathing and ventilation, we're going to listen to both of their lung fields and see if we can hear bilateral breath sounds. If there's an inhalation injury suspected, even as part of the burn injury, you're going to just want to put them on 100% FiO2 by a non-rebreather while you're sorting everything out. The signs of an inhalation injury would be extensive soot in the mouth or throat, if they're having voice changes, coughing up carbonaceous sputum, having shortness of breath, or the very concerning sign of stridor. Now, if you're seeing stridor, that's probably someone who needs to get an advanced airway in immediately. When I think about inhalation injuries, I divide them into supraglottic and subglottic injuries. So the supraglottic injuries are going to be everything from the vocal cords up, and these are the most common inhalation injuries. This is going to be someone who breathed in some superheated air or steam or smoke, closed off their glottis, and just got a quick burn to that upper airway. They'll typically have sort of worsening shortness of breath. They'll say their voice sounds different to them, and it'll sound gravelly to you. And they may need to be someone you need to consider getting an advanced airway in early, just because they are more likely to develop edema as time goes on, especially if you give them fluid resuscitation, and they'll need to get an advanced airway in place to avoid disaster. A subglottic injury is more of what most people call a true inhalation injury. So that's going to be someone who breathed in the toxic products of combustion into their deeper airways. So went into their bronchi and their bronchioles, and now those are coated in soot. That has two effects. It's going to cause almost chemical burn to the bronchi and bronchioles, and it's going to have all of the heat effects as well. So they're going to be coughing up thick carbonaceous sputum, and they're going to have progressive hypoxia that develops over the course of the next usually 12 hours. If you saw a chest x-ray on someone early who had a subglottic airway injury, about 20 to 25% of them will have patchy infiltrates already, but all of them will progress to diffuse patchy infiltrates over the course of about 24 hours and look like an ARDS type picture. So the reason we listen to both their lung fields in a burn injury is up to 10% of burn patients will have concomitant trauma. And so we want to make sure we assess for a hemothorax or pneumothorax these patients. That's especially true in our patients who have the fireworks injuries and in those who have road rash type injuries. So we really want to make sure that we're not missing anything else that could be going on. In patients who have extensive full thickness burns like this gentleman, they can have a tourniquet type effect on their chest that will limit their respiratory excursion. So if you're bagging someone and it's getting harder and harder to do on a long transport, that could be part of it. And they'll have progressive hypoxia and hypercapnia because they just can't get the normal chest excursion. So at the burn unit, we'll do escharotomies like they have on this guy, and that helps to let the tissue move more and help them ventilate better. For C, circulation, we're obviously going to assess their heart rate, blood pressure, and peripheral pulses. I expect my large burn patients to be tachycardic and hypertensive. So for most people, that means that they're going to have a heart rate in like the 120s, 130s sometimes, and their blood pressure is going to be high because they're in so much pain from their injury. If someone is hypotensive with a burn injury, there is something else going on that needs to be figured out. Burns alone do not cause hypotension unless they're profoundly under-resuscitated and hours out from their injury. You're going to want to evaluate all the extremities, especially if there's full thickness circumferential burns, as again, those can act like tourniquets. You'll want to elevate those extremities to decrease swelling. Get access with 2 large bore 18 gauge IVs or bigger, and you can go through the burns. That's fine. Go through the burn if you know there's a good vein there. That's great. And then if you think someone has a burn that's over 20% TBSA, you will want to start them on fluid resuscitation. This is not bolusing multiple liters. This is going to be starting in a sort of measured way to get them on track with their resuscitation. So the ABA has set up really good guidelines for this. For someone who's under 5, it's 125 mils an hour. 6 to 13 is 250, and 14 and over is 500. And for most of like the decent sized burns in like the 40 to 60% range, this will be a pretty good approximation as to where they need to be with their hourly fluid resuscitation. For D, burn patients are usually alert and oriented. They should be talking to you. They should be able to recall what happened. If they have altered mental status, again, we have to be looking for something else. So trauma would be a big cause. If they were in an enclosed fire, we think about carbon monoxide poisoning. If they maybe have an inhalation injury or they have a pneumothorax, it could be hypoxia. Substance abuse can be a cause in burn patients, but I don't like to assume that first. We need to rule out other causes. And then obviously medical conditions can lead to altered mental status like stroke or something else that may have caused them to fall into a fire. When you're assessing their level of consciousness, we want to use the AVPU method or the GCS. For E, we're going to completely expose and assess their injuries, examine for the major injuries, and then cover them back up right away. If they have a small burn, less than 5% TBSA, you can cool it with some like lukewarm saline or water and just get it from progressing any further. Larger burns, we don't want to cool them because those patients will often have problems with hypothermia, so you're better off just to look and then cover them up with dry sheets. If you're able to use warmed IV fluids, which is kind of a luxury when you're seeing someone on the scene, that's a great option for those large burn patients. When we're doing the exposure, we want to take a look and figure out what their TBSA is. So the TBSA is going to be all 2nd and 3rd degree burns. So anything that's red and not sloughing, we won't count in our TBSA. It's got to be sloughing or blistered or leathery or white. It has to look floridly abnormal and not just like a sunburn. And then we get to include that in our TBSA. The rule of 9s is a great first place to start, but most people don't burn their entire torso or their entire leg. And so that's good for big burns, but for smaller ones, I think the palm method is easier. And for kids, it's definitely easier to use. So using the patient's hand, you'll go from their fingertip to the crease of their palm, and each one of those on the patient is 1% TBSA. So on a toddler, you want to look at their little tiny hand and count that as 1% TBSA. And if they're over 20%, then you start those fluid resuscitation per the ABA guidelines. You're going to cover the burns. If you're just getting them to a hospital, you can put clean, dry sheets on them. You can put the backside of a Chucks on them, that waterproof side. Or if you're in a hospital setting, you can apply saran wrap. That's what we prefer at UW. Don't put any salves on it. Just put saran wrap on it and send them to us. It keeps it moist, it keeps it warm, and it decreases their pain. We're going to have to clean it anyways when we see them at the burn center, so don't put anything on it. We don't want to wrap chemical burns, asphalt burns, or tar burns in saran wrap though, because if they haven't been fully debrided or fully neutralized, that can make the burn worse. So you can just sort of cover those with a light sheet once you've finished cleaning that area. And the last and most important thing I think is the ABA Burn Center referral criteria. So the short version of this is basically anyone with a complicated burn should go to a burn center. So that's going to be burned kids, large burns, full thickness burns, electrical, chemical, inhalation burns, burns in people with complex social situations, burns in people with complex medical problems. Those are all going to be reasons to send them to a burn center. We have the resources to deal with all of those issues. So anything that's more complicated than like a couple TBSA on someone's flank probably needs to go to a burn center for further care. All right, so on to the summer burn emergencies now. We're going to start with bonfires and brush fires. And like I said, I'll go through sort of what the general injury patterns are, what to look for in your first assessment, transport concerns, and then we'll go through a bunch of cases for each of these different types of summer burn emergencies. So bonfires and brush fires are, like I said, the bread and butter of our summer burn emergencies we're going to see. They're typically normal flame injuries that you would see from any sort of accident, but sometimes people like to throw compressed aerosol cans into their fire, or they're burning trash and they don't know what's in it. And so they can actually get shrapnel injuries if one of those cans explodes or something else happens, because that does happen, that people are just burning a huge pile of trash with no knowledge of what's inside of it. So that is definitely something that we can see. Usually, though, it's just pouring gasoline onto a fire or pouring lighter fluid or trying to jump over a fire or some other fun reason to be next to the fire. Multiple victims is not common. Intoxication is common. Rarely these patients have like polytraumatic injuries. And also it's really rare for them to have an inhalation injury. Even if it flashed up in their face, it's not like they were trapped in a confined area breathing in smoke. They usually close their mouth and their eyes in that moment and just have a flash injury that can look really concerning on their face. But if they're not having any of those other signs like hoarseness or stridor or shortness of breath, there isn't a lot of reason to be concerned about the airway injuries. So immediately, we want our patients to stop, drop, and roll, hopefully before we get there. When we see them, we'll want to remove any burned or burning clothing if possible. You can leave things that are stuck on the patient, cool the small burns, and then we can assess for any other traumatic injuries. In transport, we're going to want to establish large bore IV access and then start appropriate fluid resuscitation depending on their total TBSA you calculate of their burn. These burns are going to be incredibly painful, so you're going to need IV narcotics, and that's a theme for all of our burns. And we'll want to cover them with clean, dry blankets and sheets. So, on to the cases. So our first one's a 38-year-old man. He tripped and fell into a bonfire. He was presented to an outside hospital where they wrapped his wounds up in saran wrap after washing them, updated his tetanus. They calculated his TBSA here to be about 2%. So he is not someone who needs fluid resuscitation, and he was transferred to our burn center. You can see some of those burns on his fingertips and his palms look a little deeper. They're gray and white. But the good news is that the palm skin is incredibly thick and durable, so often this will heal on its own with good wound care. That knee burn also was able to heal with good wound care, so no further interventions needed for him. Another patient was a 21-year-old man who was pouring gasoline onto a fire. It flashed back at his hand, and he has this sort of weepy red to white looking hand injury. He came straight to our burn center where we cleaned it, updated his tetanus, and as we were doing our debridements on a regular basis, we found that the area over his hand was a deep partial second degree burn, and that ended up needing grafting. So you can see there in the second picture, he's got those new skin grafts that are meshed, and that has healed in really well for him. Another one, similar story, 25-year-old burning weeds with gas, and they flashed back onto her. She drove herself into the ED by herself. They wrapped her up in saran wrap and transferred her. And when we saw her, she initially had these big blisters that went all the way up her arm. We gave her some good medication, wiped off those blisters and all that devitalized skin, got her in a good wound care regimen, and her wounds healed without needing any surgery. So you can see the final result there is a reddish pink but healthy skin that healed. So these were all smaller burns that were easily managed, transferred to our center, and for the most part healed relatively quickly. Our next one's a little bit of a bigger burn that you might see. So this is a 60-year-old man who fell asleep near a fire and probably fell into it. He was found about 16 hours later, so way behind the 8 ball in his resuscitation. He got brought to an outside ED where they immediately intubated him. They estimated his TBSA to be 60%. He had burns to his anterior torso, posterior torso, bilateral upper extremities, neck, and parts of his face and head. They got access, and they placed his IVs actually through his burns in his arms, which was great, and they started giving him fluid resuscitation. He was transferred to our burn center. And there you can see that leathery, full-thickness burn on his back. So that's a whole entire back there. So that, I would just say 18%. Good, we can calculate that easily. And so he was front and back with both of those. When he arrived to us, he was critically ill. He had a pH of 6.9. He was in acute renal failure. He was on the vent. And we had high peak pressures alarming on our vent. Earlier, I talked about how the chest burns can act like a tourniquet on the chest, and that's exactly what was happening to him. So we did immediate arm, chest, leg escharotomies at the bedside, and we started him on renal replacement therapy immediately as well. Here he is with those escharotomies that have released and allowed him to breathe. About 12 hours later, we took him to the operating room and got that eschar off of his chest to help with his resuscitation. Unfortunately, about 36 hours later, he developed abdominal compartment syndrome and required a decompressive laparotomy and was later transitioned to comfort care and passed away. This patient, I think, brings up an interesting point because when he arrived, he was profoundly acidotic and he had a lactate, I believe, of 17. So there was concern that he might need a cyano kit, and he received a cyano kit. I think it's a common reflex if we see someone who's really acidotic and has a high lactate to just give them a cyano kit. For the most part, that's harmless, and I think it doesn't cause any problems. I would say that cyanide poisoning is incredibly rare, though. You have to be like trapped in a burning plastics factory or near a ton of vinyl that burns and you breathe that in. And that wasn't the case for this gentleman either. The problem with cyano kits in people who are already really under-resuscitated is they can make for a much worse acute kidney injury. So they can develop a crystal nephropathy that just worsens their kidney function as well. So unfortunately, he did get a cyano kit. I don't think it mattered in the end, but it's not always the right thing in someone who's acidotic, who's got a burn. All right, so that was the bonfires injuries. So fireworks injuries are much, much different from a standard bonfire injury. These are going to be complex injury patterns in addition to burns. So patients will present with traumatic amputations. They'll have shrapnel injuries. They have the burns and traumatic tattooing. And the traumatic tattooing is little bits of the firework get basically driven into their dermis and leave sort of this speckled appearance that's permanent. And then there's also overpressure injuries, which is probably the most lethal effect of a blast injury that someone could be near. So they can have significant organ damage from the shockwave of the firework, depending on how strong that firework was. Most fireworks injuries involve the hands and face, and that's usually because someone is holding a firework when it explodes, or they go to look at a firework that didn't ignite properly and it explodes in their face. So that's where we're going to see most of the injury patterns. So when we first see someone who's had a fireworks injury, we want to make sure there's no other undetonated fireworks nearby. We don't need anyone else to get hurt. We're going to remove any burned or burning clothing. And when you're assessing the patient, just remember they might be hard of hearing if they were near a really large blast because they could have ruptured their TMs. Assess for any traumatic injuries. If you think they might have an eye injury and they won't open their eyes, do not force an eye injury. Just get them to a hospital where they can give them good meds and get an eye exam. And then if there is traumatic amputations, apply a tourniquet as you need to, because sometimes there'll be heavy bleeding from those extremities. En route to the hospital, you'd want to establish IV access, get pain under control. Hemorrhage control may be important if you have blood with you. It may be something some of these patients need. And then in patients who we think have had a significant overpressure injury to their chest, we're going to want to make sure we're supporting them from a respiratory standpoint. They can have apnea, bradycardia, and hypotension as a result of this. And if they're really in distress and you're thinking about flying them somewhere, you'll want to just place bilateral chest tubes before you get in the air. So that's the basics of taking care of someone with fireworks. We'll kind of go through a few cases from small to very large and kind of talk about the different steps in management for these patients. And I will say it's interesting, all of these cases I'm going to present involve mortar style fireworks, so I'm convinced that those are definitely the most dangerous ones as far as I can tell. So this is a gentleman who is using a mortar style firework. He said it may have exploded in his hand or near his hand, but based on the fact that he still has fingers, I believe it exploded near his hand. And here we can see he's got some skin sloughing. Came to our burn unit, we cleaned up all that sort of devitalized skin, and he's got some deeper burns on the back of his fingers, but those will heal in over time. He came back a week later, we did a dressing change, it was all healing appropriately. What I thought was most interesting was the amount of bruising he developed over the next week, which really shows the strength of this blast. Both of his hands and arms were like full of deep purple bruises, because these can be really harmful blasts that people sustain. So his wound's healed, no big problems there. This next man's a little bit more typical for what we see with the mortar-style fireworks that explode in their hand. He was holding one, it blew up in his hand, and immediately there was really heavy bleeding in that left hand there. Thankfully, his friends were quick thinkers. They applied a makeshift tourniquet and they got him to a hospital as fast as possible. At that hospital, they applied a real tourniquet. They performed some basic trauma imaging, and then based on the complex orthopedic injury he had and the burns he had, he was transferred to UW. So there we controlled the bleeding, got the imaging done, got his tetanus updated, washed out his wounds, and his burns did heal with time. Those ended up all being fairly superficial and mostly just sort of the sort of tar and asphalt, and not asphalt, but tar from the firework itself, all the explosive bits, and it all came off just fine. But his hand did need formal amputations by plastic surgery, and that's the hand that he ended up with, which is pretty functional compared to what he came in with. All right, this last one is probably a worst case scenario for a firework. We had a gentleman who sang off fireworks and one exploded right near him. Based on the way that we saw him, we were concerned that it hit him in the chest, just because he's got all these burns in his upper chest. He was unresponsive on the scene. EMS arrived and intubated him there before bringing him to the outside hospital. At the outside hospital, they did a basic trauma workup and they found that he had a significant lung contusion that you can see there already developing and a small pneumothorax. He had significant burns. They estimated to be close to 20%, and he was transferred via med flight. En route, he became hypotensive and hypoxic. They resuscitated him with fluids, blood, FFP, and gave him TXA as well. At UW, he was a level 1 trauma activation that we placed a right chest tube immediately and got a rush of air back that helped him stabilize for the most part. His right arm was also significantly deformed and pulseless. Once they resuscitated him for a few minutes, they brought him to the scanner to complete his imaging, and he coded in the scanner, unfortunately. He coded for about 6 minutes, and we brought him upstairs to the SICU. On this cross-sectional image, you can see that right and left lung both have significant consolidation, and that's just from that blast injury to the chest. So this is really rapidly developing. You can also see there's like the little bubbles almost with a fluid level in them, and those are all traumatic pneumatoceles. So this is someone who's sustained a significant blast injury to their chest. And the lungs are just like sponges. They just get so damaged by blast injury. In the SICU, he was on super high vent settings, 100% FiO2, and just failing. So we discussed them with thoracic surgery, and they put him on VV ECMO, which saved his life. For that arm that was pulseless, ortho came to the bedside, reduced it there, and then also performed fasciotomies at the bedside. Burn cares were performed to his chest as well. Over the next 10 days, he weaned off of ECMO as his lungs healed. He had to have his right femur and forearm fixed by ortho. His chest had some upper areas that were grafted, and then he was discharged to rehab. So this is him coming back to our clinic, fully healed and doing well. So in general, just sort of showing how rapidly damaging that overpressure injury can be to the lungs, but is definitely survivable with the right interventions. All right. On to hot ashes and coals. I don't have any cases for this one because it's pretty basic and straightforward. I wanted to include this because apparently walking on hot coals is a way that people improve their self-esteem and self-confidence. I didn't realize that. And recently there was like a whole bunch of people who were doing it at some park in Texas, I think. And a bunch of people got burnt feet. So not surprising, but something to avoid if you're looking for a self-esteem boost. So typically when we see these injuries, though, here in Wisconsin, we're going to see these in the very young and the very old. It's usually at a campsite. Someone had a fire the night before. They let it go out. And then a kid or a toddler is running around the next morning. They think the fire is out and they run through these ashes, but there's actually incredibly hot coals at the base of it. So these are going to be contact type burns from walking on those hot ashes. They can cause really deep injuries that do need surgery. And usually, like you'd assume, it involves the hands and feet most often. So we're going to, when we first see them, cool any of these small burns, make sure someone fully extinguishes the fire so that no other kids run through the fire, and then just wrap them in a dry dressing. These are going to be fairly typical small TBSA burns. Most of hot ashes and coals is just about prevention and trying to make sure that we fully extinguish our fires or have a way to prevent kids from running through a fire pit the next morning, because that's the most common way that this happens. All right, hot asphalt. This one I divide into two different patterns for the most part. So there's hot asphalt that happens at a workplace, and then there's hot asphalt that happens in Arizona on the sidewalks. So when it happens here in the workplace, it's going to be someone who trips and falls into, hot asphalt at work or has some poured on them, and they can result in a really deep burn because it basically sticks to them and burns their skin quite deeply before they can get it off. Interestingly, concrete too can cause alkali burns, and the thing about that is that people will be working with concrete for a few hours and not notice that they repeatedly dipped their knees in it or something else. And the next day, they've got pretty deep burns on their knees that will often need grafting. So that's sort of a unfortunate thing about concrete work as well. For the barefoot plantar burns or the Arizona sidewalk burns, these are going to be people who typically have desensate feet, and then they walk across a surface that is way too hot. Like you or I would step on it and jump off of it, but they can't feel it. Most often, those patients present in a delayed fashion, so they'll come in a few weeks later, and they'll have like really thick, ugly scar that's developed, and it's just from walking on really hot sidewalks. You'll see a lot of PSAs about it too, to like avoid putting our dogs on those hot sidewalks because they can also get like little paw burns, which is so sad, but they usually let us know if that's happening to them. So for these ones, the initial assessment, you're going to want to remove any clothing that's affected by the hot asphalt. And I'm talking about the acute asphalt burns, the ones that happen in a workplace most often. Try not to get any on yourself. If it's stuck to the patient and it's cooled down, don't try and peel it off. Because if you try and peel off the asphalt, you're going to peel off their skin. And it's not going to be fun. We have to use special degreasers to get the asphalt off, and even then we end up peeling off some of their skin. But we want to make sure that they've got good medications on board and that they're comfortable and we can dress it right away. So just if it's cooled down and it's stuck, leave it stuck. Get some IV access for pain control, and then elevate any extremities that have the burns. So here's an example of a gentleman who fell into some 300-degree asphalt. He was seen at outside hospital first. They just tried to gently clean the wound, and that's what we got. They updated his tetanus and transferred him to us. We debrided them under sedation for him, and then got him in a good wound care regimen, and he slowly healed in over time. So it did not end up needing grafting, thankfully, because it was more of a speckled sort of wound. All right, we're on to our last summer burn emergency topic, and one that I have seen way too much of this year. There's been so much road rash. So when we think about road rash, it sounds kind of boring, but usually the patients that have significant road rash injuries are polytrauma patients. So these are usually someone who fell off a motorcycle while not wearing protective gear, or they were ejected from a car during a car accident. Usually the road rash looks really dramatic because it can be their entire body, but that's usually the least of their worries. There's often spine fractures, intracranial bleeding, intra-abdominal bleeding, other things that we have to look for first. So it's really most important when you're seeing road rash acutely to look past the road rash and try and figure out what else has happened to the patient. So in your initial assessment, you're going to want to stabilize their spines, go through your standard ABCDE approach for trauma, and make sure that you're assessing them for other injuries. Control any hemorrhage, and like I said, mostly treat like a trauma. You're going to want to make sure that you cover them in warm, dry sheets. All of that road rash will weep, but it's not going to cause huge hemodynamic shifts in that acute period. So you can just get them covered and warm, and then otherwise assess them like you would any other major trauma patient. So we've got a few cases to kind of illustrate this. We got a young woman who was bounced out of the bed of a pickup truck and rolled across the ground, basically. EMS met her at the scene, found her on the road, applied a C-collar, got IV access, and brought her straight to UW. When we saw her, we found that she had multiple rib fractures and a clavicle fracture, and thankfully that was about it for her traumatic injuries. And then road rash over much of her body. I just have a few representative pictures, but she had significant road rash all over her body that required quite some time to heal. Our next patient is a gentleman who was dragged under a car as it rolled down a driveway. He was seen at outside hospital where trauma evaluation was performed and relatively negative. It was his only injury, and he transferred to our burn center again and healed with good wound cares. So yeah, these can be pretty significant looking, but usually not their biggest problem. Our last one is a 40-year-old man who was involved in a motorcycle crash versus a deer. He got launched off his motorcycle and skidded along the road. And as you can see there on his chest, he's got full thickness burn. So that is that white, leathery burn. It looks different from the other 2 road rashes we saw, which look partial thickness, which is why they could heal. But this gentleman had that really deep looking burn. He had a trauma evaluation at the outside hospital. They found C-spine fractures and rib fractures, and he was transferred to our burn unit for management of mostly his burn injury. We found that this was definitely full thickness and was not going to heal on its own. And once his traumatic injuries were stabilized, we took him to the operating room and did a split thickness skin graft. He was able to recover pretty well from that and discharged about a week later. This is him as an outpatient, still healing in the edges of that graft, but otherwise doing very well. All right, so that was kind of a whirlwind approach to summer burn emergencies, but I think the main takeaways I want are to use your standard ABCDE approach to any major burn or trauma patient. So just no matter how traumatic or gruesome their injuries might be, make sure you go through your standard checklist when you're assessing someone. Fireworks injuries and road rash patients are often going to be polytraumatic injuries, so make sure you're looking for those other injuries in addition to their wounds. And then any hospital with large, or any patient with large wounds, no matter what's going to require complex care, just because any large wound management usually requires a multidisciplinary team. And they're typically going to be best served somewhere with a burn unit. So obviously we love to take care of these patients, and we'd love to help out with any that you're taking care of as well. That is all that I have for our cases. I know I kind of zipped through them all, but I will be happy to take any questions now, and we can go back and talk about any of the different scenarios. No, actually, we tend to use both. So I think that in conjunction, they're best. So if you have the ability to give small doses of ketamine, in addition to a narcotic, that tends to work best for our burn patients. So even in the burn unit, when we're doing our daily wound cares, we'll give small doses of ketamine with narcotics, and that seems to really help them the most. That's a good question. So if someone has a lot of alcohol on board, they'll tend to be a little bit more dehydrated, but actually we tend to see bigger impact from methamphetamine. So there's been a lot of studies in the burn world about different substances and their impact on a burn resuscitation. And for whatever reason, methamphetamine causes much higher volumes of fluid to be needed in patients who have been burned. Alcohol will have to deal with their normal withdrawal if they are chronic alcoholics, but that's something that we're used to dealing with. And otherwise, it doesn't have any major impacts other than probably a prolonged hospital stay and some degree of delirium down the road. But in terms of their resuscitation immediately, it doesn't usually have a big impact. So paralytics aren't typically contraindicated. We just don't want to use depolarizing paralytics like succinylcholine in a large burns. So it's going to depend on what you have. The theoretical risk is hyperkalemia in a large burn. I would argue that in a smaller burn, if it's the only paralytic you have on board, then you've got to use what you got. But we do prefer to avoid succinylcholine and other paralytics like that in burn patients just because it can cause, life-threatening hyperkalemia. In terms of drugs that are preferred, you can use etomidate, ketamine, whatever you're most comfortable with. It's not going to cause major problems down the road. Obviously, you use etomidate, that can cause hypoadrenalism in critically ill patients, but that's relatively rare. So I would just use whatever you're most comfortable with for intubating these burn patients. Yeah, no, in a burn patient, especially someone with a major burn, so over 20% TBSA, warm fluids are the way to go. We are often battling hypothermia once they get to the burn unit. So anything that we can do to stay on top of their temperature is incredibly helpful. So that's a great question for which ICU they go to. If we find that it's not a hard line, but if their traumatic injuries are relatively minor, so they have a few ribs broken, but they have 40% burns, they're gonna be better served in a burn unit. If someone's got a major head injury and they've got multiple orthopedic injuries and they end up on ECMO for something else, then they're going to be better served in an IC, like a surgical ICU. We work pretty collaboratively. So at UW, our burn unit is actually, it can flex to any kind of ICU bed. So they'll often, if they have a big burn, come to our burn ICU no matter what, just because our nurses are more comfortable with the wound care. And they manage SICU patients day in and day out, as well as MICU patient, neuro ICU patients. So they're pretty comfortable with whatever comes at them. So I'm not sure how it is everywhere, but for us, we're able to take basically anybody with their injuries into our burn ICU, with the exception of ECMO patients who have to go to the surgical ICU. So in burn patients, antibiotics are actually contraindicated. I would not be giving antibiotics up front, especially in large burns. So in really big burns, a problem that comes down the road once you get them through their initial resuscitation is actually antibiotic resistant infections. So in burn, we like to avoid using antibiotics basically until we know exactly what we're treating. So prophylactic antibiotics are not preferred for burn only patients. If someone's got an open joint or an open fracture, you're going to want to give them something with gram-negative coverage. So ideally Zosyn or something similar to that. And that's just to prevent osteomyelitis. If they don't get it before they come to us, we try to give it within the first hour of arrival at UW. But burn only, no antibiotics. If you can get an IV, that's great. But if you can't get an IV, place an IO. I think we all know that IOs are painful to infuse through for patients who are conscious. And if you're giving large volumes like you would for a burn resuscitation, that can be challenging to manage. But IVs are best if you can get them. Not in most house fires, to be honest. If they had a significant inhalation injury and they were doing terribly, like hypotensive and hypoxic and otherwise doing awful, I think it's fine to give a cyanokit as kind of a Hail Mary to see if we can save them. I think carbon monoxide is probably going to be the more likely culprit. Along with an inhalation injury. True cyanide poisoning is just really rare. There is one patient I saw with cyanide poisoning I wanted to correct, and she was someone who was trapped in a nail salon that was burning down, and she had very interesting chemical exposures, and she developed cyanide poisoning. But otherwise, they're incredibly rare, even in modern homes with all the plastics around. So usually not needed. If you can get them controlled with ketamine, Versed, propofol, whatever sort of sedative, and fentanyl, like narcotics and sedatives together, we don't usually need to paralyze our patients. I only paralyze my burn patients if they're having a really hard time with the ventilator or we're having other issues in terms of like critical care down the road. But for your initial management, I would only paralyze for intubation. And then I would just get them onto a good sedative and narcotic pain control regimen. And that should be adequate. Because otherwise, if you're not managing those two, their pain and their sedation adequately, they're going to be profoundly hypertensive for you if you paralyze them. So I would just try and use your other medications to get them under control. I don't have any new frostbite treatment updates. I'm still trying to work on our data from last year, but I think the biggest thing that we're going to be talking about next year is doing rapid rewarming at outside hospitals. Because a lot of our patients, I think, come in frozen and then slowly defrost over time, which is pretty harmful for the tissues. So we're probably going to be doing more teaching and more outreach about how to do rapid rewarming through submersion in warm water buckets, because I think that'll help save a lot of tissue.